Dr. Uh, will you please project the slide of introduction? So to counter Piyush, we have Dr. Sunil Kumar Kota, who is a consultant endocrinologist from Behrampur, Odisha, and he has huge uh, work to his credit. He is the best letter to editor trophy for ESICON, and he is receiver of many awards, and he has done some good uh, national and international uh, research work, and he has received RSSDI 2020 award for the best innovation in the diabetes care during challenges in the times of COVID-19. And Dr. Sunil Kumar Kota will speak the other molecule against uh, glargine U300. Over to Dr. Sunil Kumar Kota.
Thank you so much, sir, for this very kind words of introduction. First of all, very good morning to the respected chairpersons, to the august audience, and thanks to the organizers for having me here and asking me to talk in favor of the molecule Degludec after that wonderful deliberation in favor of Glargine 300 by Dr. Piyush. So I would rather like to put it across this way. This is a debate between the delightful and depthful Degludec versus the so-called and the self-projected gorgeous Glargine. So what I think, it is a debate between something which is a redefined molecule versus a refurbished molecule. At the outset, I would like to also make it very clear that don't expect any slandering business between us, because we all are in favor of science. हम science के तरफ से हैं, as per this famous scene in the movie Three Idiots. But it doesn't stop me from going back to the age-old classic by William Shakespeare about this classic movie, which is the Much Ado About Nothing. We all understand the mechanism of protraction, which has already been alluded to by Dr. Piyush sir. The Degludec forms stable multi-hexamers, then glargine U300 is a up concentration of insulin glargine, giving rise to larger precipitates and thereby translating into slow rate of absorption. Supposedly you are on a journey and you get a bumpy ride at the outset itself. Are you going to proceed with the journey? At least I am not. And let me take you back to 2015, where glargine 300 is compared with that of its predecessor unit U100. This is the steady state pharmacodynamic properties in type 1 diabetic patients, and surprisingly the 24-hour glucose lowering effect of glargine U300 was 27% lower compared to unit 100. Now we are of course indulging into a basal debate, and let us look at some of the points when we talk about when we try to distinguish rather between two molecules. First of all, what is its efficacy in terms of A1C reduction? What are the additional benefits in terms of hypoglycemia reduction, addressing the glycemic variability? And what about its usage in special population, especially patients having renal impairment? And what about its usage in different set of population where insulin is used naively or used on top of another insulin? And also whether it can be given in form of co-formulation, whether it can act as a team member. So this is the again the study, the glycemic variability study done by the Novo Nordisk team in the 2017, a double-blind crossover randomized study, 1:1, 60 patients of type 1 diabetes. Initial period 0.4 unit per kg Degludec versus U300 was given. Then with a 7 to 12 days of washout period where the NPH was used, again at 12 days, there was, you can see there was a switch from Degludec to glargine and glargine to Degludec. And very importantly, at the bottom, please have a look at the number of clamps used during the study period. It was 3 clamps during both the study periods. And the primary endpoint was to look at the day-to-day variability, which was 4 times lower in favor of I-Degludec, that is the day-to-day variability. And if you look at the day-to-day variability during 2-hour dosing interval, bearing initial 2, that is 0 to 2, and the last 2 hours, that is between 22 to 24 hours, during rest all hours, the Degludec is significantly scoring better in terms of reduction of glycemic variability. And if we talk about within day variability also, the Degludec is 37% having 37% lesser chances of within day variability. And when we talk about the potency, which is largely missed out from my predecessor's talk, the Glargine U300 had a 30% lower potency compared with Degludec. And another secondary endpoint, the distribution of glucose lowering effect in 6-hour intervals. You can see the glucose lowering effect was evenly distributed in patients receiving Degludec. It was somewhere between 24 to 26%, but in patients receiving Glargine 300, it was wide flung between 17 to 35%. So they go on to conclude that Degludec had a 4 times lower day-to-day variability and 37% lower within-day variability compared with Glargine. Degludec had a more stable and even distribution of glucose lowering than Glargine 300, and Glargine 300 had an estimated 30% lower potency compared with Degludec. Of course, it is going to face a retort by the competitor. This is the Sanofi study, which Sir was rightly alluding to in 2018. 0.4 unit per kg per day at this particular dose, Glargine 300 provided 20% less fluctuation, that is accepted. But the entire study period used only 1 clamp, wherein Novo used 3 clamps during the study period. Surprisingly, when the dose scaled up to 0.6 unit per kg per day, the difference was not statistically significant. Now let's have a tabular differentiation between these two studies. The day-to-day variability was 4 times low with Novo Nordisk, which was not studied by Sanofi. There was no switching between the molecules in Sanofi, wherein in the Novo Nordisk study, you can see there was a switch and 86% patients showed improvement when switched from Glargine to Degludec, and it started worsening when they were shifted from Degludec to Glargine, which was not happening with Sanofi study. Only parameter studied was within day variability, that was 37% lower with IDEG in Novo Nordisk study and 20% lower with the Sanofi study. You look at the p-value, which appears more significant. P is less than 0.001 over here, that is P is 0.047. And the confidence interval is 95%, that is used to look at the ambit of the study, which is only 90% in the Sanofi study. And as I already talked about, Novo study has used 3 clamps during the study period, whereas Sanofi has used 2 single clamp. And both these studies have shown there is a lesser potency of Glargine. It is 30% in Novo Nordisk study. It is 14 to 20% in the Sanofi study. And yes, sir has rightly alluded to the trial level meta-analysis published in 2018. But the basic demerits are that there were important differences in the methodology employed between the begin and addition, so they cannot be compared head-on. In fact, it would have been a better meta-analysis had there been patient-level data incorporation, but only this study was taking into account trial result level meta-analysis, so it cannot be a source of definitive comparison of Glargine 300 versus Degludec. And look at the DEVOTE trial. At least the Degludec had guts to do a CVOT comparing itself with IDEG versus Glargine 100, which also analyzed severe hypoglycemia, and it was significantly lesser in favor of Degludec, having 7,637 patients. But we do not have similar clinical trial comparing Glargine 300 versus its own predecessor Glargine 100 in terms of large sample size and duration. And renal impairment, of course, studies have stated that whenever the albumin level goes down 3.8 grams per deciliter, probably Degludec is not a good choice to go ahead. But there are studies on the contrary as well. This is a clinical pharmacologic kinetic study in 2014. It says that the ultra-long pharmacokinetic properties of insulin Degludec were preserved in subjects with renal impairment. In fact, even in patients having ESRD with or without hemodialysis, the parameters studied were absorption or clearance, total exposure, and steady-state PK profiles, which were very similar. So they go on to conclude that patients having impaired renal function, they do not require Degludec dose alteration. This is very recent in April 2020. In fact, it has tried to switch from the existing form of basal insulin, Glargine 100, Detamir, and the Glargine 300 to Degludec. And post-switch, there were 3 benefits: better reduction of basal glycemia, better reduction in daily insulin basal dose, and better reduction in hypoglycemia. On top of that, renal function remained stable with a decrease in albuminuria in both the groups. So Degludec was found to be effective, efficient, and safe in renal patients with type 2 diabetic and macroalbuminuria. This was a poster presented in June 2016, ADA 2020, Indian group having Devamalya Sanyal sir as well from Kolkata, a single center retrospective observational study for 24 weeks. 3A, 3B, and 4 CKD were included, and it was found that in the sickest of patients, the insulin Degludec had lower rate of hypoglycemia in patients having type 2 diabetic and advanced renal failure. But of course, patients having 3A, the Degludec group had higher hypoglycemia attributed to higher concomitant usage of sulfonylurea. So if you talk about more advanced stages also, it is absolutely safe. Yes, I understand that there is a lot of hype and hoopla about this bright study. They say, yes, we have done some dates. Let's try to take them head on. As we all understand, Piyush sir is a daredevil and risk-taking physician. We all know him. But I fail to find the same in the bright trial. This study has taken only insulin naive patients. Why not patients who are already on insulin? Because in our Indian setup, these being costly insulins, most of the times what we see is that this insulin is added on to a patient who is already on insulin. That again is not a very uncommon scenario, but that is missing over here. And they have taken the design as a non-inferiority trial comparison to Degludec in terms of A1C change. So why sudden the daredevil approach is all of a sudden gone? We all know the results. Sir has rightly told us. But in terms of glycemic control, A1C reduction was similar. Proportion of patients reaching the goal of A1C less than 7 was similar. Overall SMPG was similar. But again, overall hypoglycemia, severe hypoglycemia, nocturnal hypoglycemia was similar, but the titration phase, as sir rightly said, the overall, the nocturnal and the severe hypoglycemia was lesser with glargine 300. But I have some questions. You have taken only insulin naive patients. Why don't you try it with patients who are already on insulin? Why do you want to play safe? And are you scared to take on Degludec head on in terms of better A1C reduction? You are just trying to prove non-inferiority. And if you are not talking about additional A1C reduction, are we not talking about only something not more than distilled water? But again, for glargine 300, sir has already told us that Degludec has its conclude study, but I am going to add one more study, that is the conform study. So we have the conform study which has tried Degludec in insulin naive patients, and conclude study which has tried to study insulin on insulin using patients. So if I'm whenever the proponents of glargine 300 are asked about quoting studies having better A1C reduction, sometimes the answer is like the one which is showed in the picture. The conform says it is the study done on type 2 diabetic patients who are insulin naive. Degludec versus glargine was studied. Primary endpoint was to look at the change in mean A1C, and the secondary endpoints were the hypoglycemia and the insulin discontinuation rates. You can see overall there was a significant greater reduction of A1C in favor of Degludec compared to glargine U300. 30% lower rate of hypoglycemia in favor of Degludec versus glargine, and again there was a 36% lesser chance of proportion of patients experiencing more than one episodes of hypoglycemia. And on top of that, let me tell you very clearly that the discontinuation rate was significantly higher with glargine 300 versus Degludec. So another knockout punch. I'm going to tell you that is the conclude trial. Again, sir has already told us there were some initial hiccups following which it was completed, and that was the Degludec U200, which is not currently available in India, but that does not preclude talking about its science because we may have it anytime soon. So maintenance period, overall symptomatic was not different, but the nocturnal symptomatic and severe was significantly better with Degludec. Total treatment period, all the three parameters, the overall, the nocturnal and the severe was better with Degludec 200. And in the titration phase, wherein the bright study says the glargine 300 is always better, here we have a study which says that overall symptomatic is significantly reduced in favor of Degludec, but nocturnal symptomatic and severe hypoglycemia both are almost having non-significant differences. So there is a 37% lower overall hypoglycemia in the titration phase. So the summary of conclude says the primary endpoint was to look at the overall hypoglycemia in the maintenance phase, which was not different. But then in the other two parameters, the severe hypoglycemia and the nocturnal hypoglycemia was significantly lesser with Degludec U200. Very significantly, conclude showed there was a 12% lower dose of Degludec U200 required. In fact, the bright study, I forgot to tell you one thing, that there was a 20% of less dosage required for U200 versus Glargine 300. Again, the post hoc analysis concludes says there was lower A1C levels in favor of Degludec, but Glargine had less weight gain in favor of Glargine U300. Something missing is the cost effective analysis study. This is a study of cost effectiveness of insulin Degludec versus Glargine in type 1 diabetes. In both type 1 and type 2 diabetic, Degludec is likely to be associated with cost effective and is associated with incremental cost effective ratio, which is below the acceptable threshold. In type 1 diabetes, the lower cost is predominantly driven by lower insulin cost because of lower daily dose that is required. In type 2 diabetes, the lower cost is driven by lower costs of severe hypoglycemic events due to significant reduction in number of events with Degludec. And they are talking about TIR. Yes, we do appreciate the 1K study, but this is a study in type 2 diabetic patients, which says there is a comparable efficacy and the mean percentage of time within the range for both these molecules are similar. So what about the approval for type 1 diabetes in India? This is the information that I could gather. The esteemed chairperson or my opponent can always correct me if I'm wrong. DCGI has given approval for Degludec, which can be safely given in age 1 year onwards, but the package insert in Glargine 300 in India says it is not approved below 18 years of age, though it is US FDA approved. But we all understand that Glargine has no role in premixes because of its acidic pH and high zinc content. But there is a multinational consensus statement led by Sanjay Kalrasar, which has guided us about the pragmatic use of Degludec and insulin aspart co-formulation. So after presenting all these facts, if my opponent, with due respect, Dr. Piyush sir, still vouches for Glargine 300, I think he is trying to just fool us. But again, the chairpersons and the esteemed audience are not here to be fooled. The Bright versus Conclude. The Bright is a non-inferiority trial. Conclude was more daredevilish. It was a superiority trial. But again, the Bright was trying to look at only change in A1C. It was trying to point non-inferiority trial, and it was taken only insulin naive patients. But the Conclude has taken insulin experienced patients, and we have another study that is the Confirm, which has also taken insulin naive patients having type 2 diabetes. So this basically takes to the summary slide. The Bright says, yes, similar HbA1c and SMPG, but significant lower fasting glucose with Degludec. Conclude says, lower HbA1c and fasting plasma glucose with Degludec. Both Bright and Conclude say that Bright says 20% lesser dose is required for the Degludec. Conclude says 12% less doses of Degludec is required to get to the goal. Hypoglycemia, Bright says in the initial titration phase, all the parameters are in favor of Glargine 300. The Conclude says the titration phase overall hypoglycemia was lesser with Degludec 200, but other two parameters, the nocturnal symptomatic and the severe, it was significantly lower with Degludec. Of course, the weight gain parameter is in fact in favor of Glargine. Yes, we like Sachin Tendulkar predominantly because of his batting. We also like when he does some good bowling, and also like when he does some good fielding on the act. But when he does only good fielding, but he doesn't do the primary action of good batting or A1C reduction, we do not like him. Should be useful and of benefit of at all stages. By saying that, I mean to say that the Glargine 300 has studies in only in insulin naive patients. It does not have many studies wherein it is used in insulin experiencing type 2 diabetic patients. And the Glargine doesn't have a team spirit, it seems, and because it doesn't set in with the other analogs to give us a good premix formulation. So thank you all for that patient listening. Over to you, chairpersons.